Thank you all for joining us for today's webinar, Osteoporosis and the Female Patient, Premenopause. My name is Jessica Monmany, and I am the Senior Education Associate at ARHP. I will be moderating today's webinar. Before we begin, I would like to share how you can receive continuing education credits for this webinar. In order to receive credit, you must take the pre- and post-test. If you have not yet taken the pre-test, please click the link provided to you in the reminder email or via the webinar's chat box. You can also use this box to enter questions throughout the webinar, which will be answered by our presenter at the end. About an hour after the conclusion of the webinar, you will receive an email from Caitlin Borthwitz, ARHP's Communication and Education Associate, with a link to the post-test survey. Your continuing education certificate will be generated upon completion of that survey. In 4 weeks, you will receive another email with a link to a follow-up evaluation. We ask that you complete this evaluation to let us know how you have incorporated what you've learned during this webinar into your work. Completing the pre- and post-test, as well as this follow-up evaluation, helps ARHP ensure that we continue to meet your educational needs and interests. Thank you in advance for your time and feedback. At this time, I would like to introduce Dr. Cheryl Lambing, today's presenter. Dr. Lambing graduated from the UC Davis School of Medicine and completed her residency in faculty development at VCMC. She has been serving on faculty since then and also serves as the Director of Continuing Medical Education Programs. Her special interests include rheumatology, osteoporosis, and women's health. She speaks nationally on these topics, lectures for the AAFP, and serves on national education panels building educational programs for primary care physicians. She's worked on numerous educational projects for both the National Osteoporosis Foundation and ARHP. Dr. Lambing's full bio is available on ARHP's webinar web pages. We're thrilled to have her with us today, and I'll hand it over to her. Dr. Lambing, you have the floor.
Wonderful. Welcome, everyone. Today we're going to spend time going over really the approach to history and preventative care. I'm going to go ahead and advance to disclosures and commercial support. The commercial support, this program, was made possible through an independent educational grant from Amgen. Additionally, we have provided disclosures for all members of the planning committee, as well as the clinical advisory, medical writer, and ARHP staff. Learning objectives. By the end of this presentation, you will be able to list the risk factors for osteoporosis and determine why that is important. To describe the factors that affect peak bone mass, or what I call bone acquisition, which is key as we think about the lifespan of women. To review the effects of hormonal contraception on bone mineral density. To discuss osteoporosis prevention strategies with patients, which is really what most of us are thinking. How do we take this information and apply it clinically as we've seen patients? And then think about screening appropriately patients at risk for osteoporosis. Now, the agenda. We're going to go over a little bit of overview with regards to bone health, risk factors for osteoporosis, diagnosis, contraception, the female athlete triad, eating disorders, and then taking it further, thinking about the importance of history, thinking about the whole woman, whole person care. What is the impact of diabetes? Inflammatory joint conditions typified by rheumatoid arthritis, inflammatory bowel disease, hyperthyroidism, hyperparathyroidism, and the foundation, the key, which is that of prevention throughout the lifespan. Additionally, we have a module, part 2, let's say, osteoporosis in women after menopause. And after this webinar, you will receive a link to register for this webinar, and it's scheduled for Thursday, October 27th. Okay, let's get going. We're going to move on to osteoporosis and bone health. And I'm going to set the stage that, in fact, as we think about rheumatology, as we think about musculoskeletal conditions, osteoporosis is the #1 musculoskeletal condition. The #2 musculoskeletal condition is osteoarthritis. And think about how many patients you see in your practice who might have osteoarthritis. And yet, osteoporosis is the #1 musculoskeletal condition. So the importance of bone health becomes critical throughout a woman's lifespan. And I want you to think about this. We're going to talk about the roots of osteoporosis really originating in early childhood, the lifespan. AAFP, American Academy of Pediatrics, now wants us to assess infants and think about vitamin D, think about calcium in children, adolescents, young women and men, etc. Now, bone is much more dynamic than we ever thought. Research demonstrates that it's really dynamic and it's more of an endocrinology organ, and we'll talk about that. Bone provides mobility, support, protection. It's really scaffolding for all the other organ systems in the body, and it stores essential minerals. The continual process of bone removal and replacement happens throughout the lifespan. We're going to focus on bone acquisition and peak bone in the young adolescent and young adults. Promoting bone health really behooves us. It helps modify the rate and future risk of osteoporosis. Osteopenia, what I call low bone mass or reduced bone mass, is bone mineral density that is below normal and may lead to osteoporosis in the future. Now, we're going to start with an audience poll. How many adults in the United States have osteoporosis? 2 million? 5 million? 10 million? Okay, great. We've got 2 million, we've got 5 million, we've got 10 million. And one of the keys that I would say is, remember, osteoporosis is the #1 musculoskeletal condition in the U.S. So the question, how many adults in the U.S. have osteoporosis? The next slide gives you osteoporosis statistics in the United States. 1 in 3 women and up to 1 in 5 men over 50 will sustain a fracture due to osteoporosis. Again, #1 musculoskeletal condition. U.S. adult population affected by osteoporosis, 10 million, so higher than a lot of you anticipated, and 43 million have reduced bone mineral density or osteopenia. By 2020, 61 million persons in the United States are expected to have reduced bone mineral density. And here's the key. 75% of hip fractures occur in women, and we're talking about women in this webinar. Hip fractures, actually all fractures, thinking about vertebral and hip, have significant morbidity and mortality rates, but hip fractures in particular have rates of mortality to 20 to 24% in the first year. So we want to really impact prior to even the first fracture, and certainly for hip fractures. But hip fractures really change the outcome. Fractures in general are associated with chronic pain, reduced mobility, disability, and increased dependence or loss of independence. So let's start with bone development in young women. Boys genetically start off with more bone mineral density than girls. And there's also architecturally differences between boys and girls. This is one study, a prospective study of boys and girls aged 8 to 14. You might be surprised, mean bone age, mean peak bone mass of Curo happened 2 years earlier in the girls. Why? It coincided with the mean age of menarche. Now, you might not know this, though. Bone tissue accumulated between the ages of 11 to 13 approximates the amount that's lost in the 30 years following menopause. That's huge. So if we can pack on what I call a bone bank, if we can pack on peak bone mass or achieve a bone bank of which we have remodeling, that's huge. So this is a critical time in a woman's life. A 10% increase in peak bone mass in childhood reduces the adult risk for osteoporotic fractures by 50%. What impacts it? This is what I call genetically pre-programmed, and my background is in genetics. If we don't have adequate diet, if we don't have adequate exercise in adolescence, this can result in weaker bones and certainly a risk for reduced bone mineral density or osteoporosis and fractures in adulthood. So this is where the money is, achieving the peak bone bank, genetically pre-programmed peak bone mass. Now, the next slide talks about peak bone mass and bone mineral density. The majority of adult bone mass is accrued by age 50, and there's a number of remodeling factors. 90% of bone mass is achieved by that young adulthood, and peak bone mass is influenced by genetics. It's 75% genetically pre-programmed, but there are other influence, environmental factors, let's say. For instance, gender. Peak bone mass tends to be higher in men than women, and I've already alluded to there are architectural differences. And after puberty, men tend to acquire more bone mass than women. How about race? Interestingly enough, African American females tend to achieve a higher peak bone mass than Caucasian women. Hormonal factors. Estrogen can be very protective to peak bone mass or achieving peak bone mass. Nutrition is huge. Calcium, vitamin D, protein. Physical activity is key to achieving peak bone mass. And then you think about what might be helpful. Physical activity looks like high-impact exercises, short bouts, and strength training is especially helpful. Lifestyle, we're well aware of the risks for smoking, alcohol, and also a sedentary type of lifestyle. Now, that plays into the determinants. If we don't achieve an adequate body weight, if we have low body height, delayed puberty, calcium imbalance, and physical activity, we have increased risk. Now, the next slide, nutritional effects on peak bone mass. The building blocks for quality bone, calcium and vitamin D. Dietary calcium predicts 10 to 15% of skeletal calcium retention during adolescence. And think about what our young people are eating. Are we achieving adequate calcium and vitamin D? Being outside can be helpful, but a lot of the activities are inside. Key, protein plays a role in bone mass acquisition as well. Low protein intake lowers the production and action of a growth factor called insulin growth factor, and it's a critical mediator that directly regulates bone growth and bone density. So protein also plays a key role in bone mass acquisition. This is key as we think about setting up the bone bank. The next slide, what are the risk factors? And I think we're accustomed to seeing this. We're accustomed to seeing this when we look at older individuals. There are some non-modifiable risk factors, certainly age, female gender, a family history of osteoporosis, a previous fracture, ethnicity, and I've already erased that in some fashion, menopause, hysterectomy, long-term corticosteroid therapy, and I'm going to talk about that as one of the chronic conditions. Rheumatoid arthritis as a surrogate for other inflammatory conditions, primary and secondary hypogonadism in gentlemen. What about modifiable risk factors? Alcohol intake, smoking, low body mass index. Poor nutrition is a huge focus we'll talk about today. Vitamin D deficiency, which is not uncommon, low dietary calcium intake, eating disorders, insufficient exercise, and frequent falls. And we're going to discuss some of the specific modifiable risk factors subsequently. The next slide, DXA scans. Dual X-ray absorptiometry, DXA, is the most widely validated diagnostic tool. And we're going to focus on where its strengths lie. DXA is applied to certain sites, spine, hip, and forearm. And how can we use DXA? And you can see it is not a problem in terms of being able to obtain a DXA in an outpatient setting. Patients don't have to disrobe. It's very quickly done. It can be used to establish or confirm a diagnosis, predicts future fracture risk, and it can be used to monitor patients on or off therapy. The interpretation of the DXA is actually where we need a little bit of discussion. There's a lot of demographic information for patients, date of birth or age, sex, ethnicity. All manufacturers, all the different technologies use race in calculating Z-scores, and we're going to focus on Z-scores. T-scores can be calculated differently according to race. Really key, when we look at the report, we get absolute BMD in grams per centimeter squared for each site. We also have the skeletal sites that are measured, the region of interest, and if appropriate, the side scan. For instance, you may have dual hips, you may only have one hip, you may have the non-dominant forearm, etc. There are also going to be there's also going to be information if certain sites were excluded. For instance, skeletal sites, the spine, where there may have been prior surgery. The WHO criteria for diagnosis in postmenopausal females is applied to reports utilizing DXA, and they generally use the T-score. Risk factors including previous non-traumatic fractures are included, and central DXA measurements at the spine and femur are really preferred for therapeutic decisions, and there may be certain instances where, for instance, the forearm is very helpful. Now, when we look at that report, really what I focus on, certainly the T-score, certainly the Z-score, but I'm also looking at the absolute BMD. And you want to ask for your actual report. Many times you'll receive a summative report, and you want to ask the center to provide you the entire report, including all images. And there are some samples of DXA images on the next slide. If you look to the right, you've got a spine DXA. It's got information. You've got the region in the first column there in yellow. You've got absolute BMD in grams per centimeter squared. You've got the young adult T-score, and you've got the age-matched Z-score. On the left, you have dual hip. You have the same information, region, BMD, young adult T-score, and age-matched Z-score. Now, how do we interpret these? How do we help interpret these for our patients? The T-score, and this is utilizing the International Society for Clinical Densitometry, ISCD. The T-score. T-score is bone mineral density compared to the young adult population. That's the reference population, and it's reported in number of units, standard deviation from what bone mineral density is, above or below the average. And this is preferred for postmenopausal females. So the T-score is helpful for making a diagnosis in postmenopausal women. I like to think about these scores compared to the absolute BMD because as a clinician, if I'm trying to figure out what to do with a potassium, do I want the potassium level, or do I want it to go through a calculator and give me a score? I'm going to want the potassium. So in a lot of ways, I also want to look at the absolute BMD, and the absolute BMD change over time if I'm looking at reports over time. But today, we're going to really focus on the Z-score. The Z-score is also standard deviations below that expected, but it's based on age-matched. Age, sex, weight, ethnic or racial origin, and this is preferred for premenopausal patients. Very important when we're looking at scores, and we're going to focus on Z-scores. As a reminder, utilizing the WHO, for instance, a postmenopausal patient who has a reduced T-score, you can make the diagnosis based on bone mineral density and T-score, or based on fractures. Next slide. Audience poll. Which of the following measurements indicates a diagnosis of osteoporosis in a premenopausal patient? A Z-score that falls below the -2.0, a T-score that falls below the -2.0 with a secondary cause, a Z-score that falls below a -2.0 and a secondary cause, a T-score between -1 and -2.5, and a 10-year probability of a major osteoporotic fracture. Now, while you're looking at this, I've taught board review in many areas for a lot of years. And so my eye is drawn to, for instance, a exam question when you think about this. And I'm still waiting for our outcome. How about that? Okay, I've got 20% with a T-score that is less than or equal to -2.0 and a secondary cause, a Z-score of less than or equal to -2 and a secondary cause, or a T-score between a -1.0 and a -2.5 with a 10-year probability increase. 20%, 60%, and 20%. And I'm just going to call attention to the fact that 2 of the scores, for instance, A and C, were Z-scores, and B and D were T-scores. And we just talked about we really want to focus in younger women with regards to the Z-score. So let's look at that a little bit further. Diagnosis of osteoporosis in premenopausal women. A Z-score that is above the -2.0. So all the positives, the 0, all the scores above a -2.0 is really expected range for age. Everyone achieves their pre-programmed genetically peak bone mass to a different degree. But we may want to look at some of those individuals more closely. A Z-score that falls below that -2.0 is below expected range for age, and I might want to look further. I'm going to really focus on history, but that doesn't give me a diagnosis. I'm more inclined to think about a reduced bone mineral density with an individual that has a -2.0, falls below the -2.0, plus they have a secondary cause. I'm more likely to consider a diagnosis of osteoporosis. But when is a DXA scan indicated for premenopausal women? How often am I going to see those scores? A DXA scan may be recommended based on ISCD for these reasons. An individual that has a fragility fracture that really isn't explained by the nature of the activity. Disease. We're going to talk about some of those. Diseases, conditions, or medications that can be associated with reduced bone mineral density or bone loss. Anyone being considered for pharmacologic therapy, anyone being treated to monitor treatment, and anyone not receiving therapy in whom evidence of bone loss would lead to treatment. But this is the takeaway message. A routine DXA scan should not be done on all patients with minor positive family history, for instance, minor risk factors. It shouldn't be part of a routine medical assessment as a screening strategy or in individuals with minor risk factors. So we're not going to be ordering it universally like we think about women over the age of 65. Now, what is different as we think about our younger women in our practice? Contraceptives and bone health. What should we know? What do we need to discuss with our patients? First of all, oral contraceptives. What are the impact of oral contraceptives on bone health in women? We do know that hormones, particularly estrogen, can exert profound impact on bone growth and maturation. And many times, oral contraceptives, these are used for prolonged periods of time during a time when we consider to be bone acquisition, bone achieving, or bone consolidating times in a woman's life. If we think about the studies, if we look at the studies, estrogen-containing oral contraceptives in adolescents and young women have really provided mixed results. And yet, I shared at the beginning of the webinar, estrogen can have a positive impact on peak bone mass. What about the effect of oral contraceptives? And the next slide provides one example of a prospective study. And this looked at bone mineral density change over 2 to 3 years in oral contraceptive users and discontinuers of estrogen relative to non-users. So you see oral contraceptive users, the discontinuers of OCs, and then non-users. And the main outcome was really evaluating BMD at 6-month intervals for 24 to 36 months. After 24 months, adolescents that were using 30 to 30 microgram moderate ethinyl estradiol oral contraceptives had smaller gains in BMD compared to the non-users at the spine. At 12 months, adolescents who discontinued the 30-35 microgram pills had significantly smaller gains than non-users, and at 12 months after discontinuation, the discontinuers still differed significantly from non-users. So there's something unique about the use of oral contraceptives, the use of estrogen in the women. But the next slide shows the difference in ages, which is also very interesting, because if we think about that age 11 to 13, here's ages 14 to 16, compared to women in their 20s, 19 to 30, and the use of oral contraceptives still were different. This is also the very first time that I'm showing you something different. In pediatric individuals, in adolescents, we often will utilize a whole body DXA, which is very different than adults. In adults, we exclude the head. Certainly in pediatric patients, they will include the head in the whole body DXA. So that may be the first time you're seeing that. Nevertheless, on the A side, in the younger women, the differences in green, non-oral contraceptive utilizers, less than 30 microgram pills and 30 to 35 microgram pills, you see a difference in the impact on BMD during bone acquisition. And you don't see that impact in bones in skeletons that are slightly older, out of the adolescence. So, interesting. Estrogen, we have mixed results. What about other methods, like the contraceptive vaginal ring and bone mineral density? This looks at, again, vaginal ring versus control group. And same type of study utilizing BMD. There was no change in BMD in vaginal ring users, but there was an increase in BMD from the baseline in the control group. Also, frequently studied in bone, urinary cross-link excretion was looked at, and there was a significant reduction. In the last group, at 12 months, there was no significant difference in BMD among the three groups compared to basal values. Again, we don't know really what to take away from this, other than estrogen innately, endogenously, may be very different than our contraceptives. And this group in particular is our high-risk group. We want to ensure that we have adequate contraception for our young women. The next group is actually a look at bone health and long-term use of Medroxyprogesterone, or DEPO. This is a long-lasting contraceptive hormone, and certainly it's in print, it's in the package insert, but it may impact bones differently. And the femoral neck seems to be particularly, lots of studies here, meta-analysis of placebo-controlled trials, even utilizing, for instance, DEPO with an estrogen supplement and DEPO with placebo. What have we learned? It looks like we have recouping of any impact of losses or reduced BMD gains. However, what has become a recommendation is not to routinely order a DXA or bone mineral density in this group, because we really don't have validated DXA values to make decisions for this population. The main emphasis for this population, like all the other groups, are to really emphasize best practices. Ensure they're getting adequate calcium, adequate vitamin D, exercise, adequate calories and protein, which we're also going to focus. The next slide is that summary. The summary that demonstrates, one, that we can have impact on BMD at spine and the hip. It slows over time, and you see increases in BMD after discontinuation. We see impacts on reduction in estradiol and insulin growth factor number 1. But the takeaway for this slide is really that although there are identified predictors of BMD loss and DEPO loss, patients were followed afterwards, and they were able to recoup those losses. They were able to see reversal, and that's what's demonstrated on the next slide. The question, if we see losses, if we see impacts on the bone acquisition, can it be reversed after DEPO discontinuation? And this 3-year prospective trial looking at BMD during use and discontinuation of adolescents also checked BMD every 6 months for 24 to 36 months at the hip, spine, and whole body, and compared it to users, discontinuers, and non-users. And that information is contained in the next slide in the table. And it shows with, for instance, the DEPO users versus non-users, you had a change in the BMD. But again, the emphasis here is that it shouldn't impact use, because the American College of Obstetricians and Gynecology's committee opinion on DEPO states that although the use of DEPO is associated with loss of BMD, evidence suggests that losses in BMD appear to be substantially or fully reversible. Therefore, from a clinical standpoint, this really shouldn't impact on our use. I would consider this to be to have the ability to rebound. Now, we're going to move on to the female athlete triad. This is a great opportunity for us in the clinical field to really make connections into our community. For instance, I work with a number of the sports teams through the Office of Education. Female athlete Triad is probably becoming better recognized. Certainly you have national publications addressing it, and the coaches are certainly more interested. Female athlete Triad, you think about low energy, low availability of energy, menstrual disturbances, and bone loss, or an impact on the quality of bone. We really need to ensure that we have the ability to intervene with regards to these portions of the female athlete triad, so they do not result in disordered eating, amenorrhea, or osteoporosis. What's key to the female athlete triad is energy balance, and really it's energy availability. If you look at these individuals, they are having huge outputs of energy and many times need to be trained as to improving energy intake and energy availability. Huge outputs. If you have an imbalance here, then you end up contributing to menstrual irregularities. And it's this combination, it's really the combination of both that directly impact on bone health. What I tend to educate is you tend to educate that their coaches are telling them to eat recurrently over the course of the day, but they're not eating, and then they're expending huge energy and they're ending up with deficits. If you have individuals who are meeting their energy intake needs and matching their energy expenditures, everything is great. You've got homeostasis, you've got normal menstrual cycles, and the acquisition of bone mass is normal. However, with an imbalance, with lower energy availability, they may or may not develop disordered eating. They may have impacts on their menstrual cycle. Reproductive and bone health are certainly longer down the road, but functional hypothalamic amenorrhea increases the risk that you have low bone mass and risk for osteoporosis. Energy availability is key. Now this is where I really focus my energy, because when I'm out in the community, this is what they're interested in. Think about what the athlete is interested in. Think about what the coach and the parents are interested in. Kids come home, they got excessive fatigue, they can't do their homework. What do we see on the field? Increased recovery time, decreased training responses or adaptations. And this is where the money is, impaired performance. If they've got performance goals, they're not going to get there. They've got to have the energy in order to get there. And if they're in deficit, all the other subsequent problems develop. Often have GI complaints. Nutrient deficiencies are huge. I think about calcium and vitamin D for bone, but also there are other nutrient deficiencies. Protein, iron, you can see an increase in iron deficiency, low ferritin stores. It all impacts on their ability to achieve peak performance. There are increased risks to future bone health, and this is where I put on my musculoskeletal hat. Sure, it increases risk of stress fractures, certainly delays healing of fractures if they happen, but there are also significant impacts on the musculoskeletal system. Muscle mass, increased injuries, longer time to healing, which means they're on the injured list longer, and they are not achieving peak performance. They may have shorter seasons because they're having to be in the recovery room, they're cross-training. They may even miss their whole season window. So this is huge, and this can impact. Increased risk of future osteoporosis and fractures? Yes, but that's future. And so really we want to focus on where we can make early intervention. The more significant outcomes, osteoporosis, fractures, impaired future fertility, cardiac arrhythmias, and death are huge. Now, how do you take this message home? These impacts are huge. Think about the car. Hang on one second. Think about the car. This is how I explain it to the coaches and the parents. I'm trying to go back on this slide. Everyone has a car. Car needs gas, car needs oil. If you run out, the car runs poorly. It may break down and leave you stranded, but it certainly does not achieve the performance goals. These issues can be reversible if caught early. If we intervene and recognize early, Otherwise, you've got the last group, that last 4 bullets. Those may be a real problem, and you may have irreversible changes. So you've got to have a takeaway message. Connect to your community and have a message that they can really understand. In the car, pretty much everybody's got to get to practice, so a car makes sense. Recovery rate. This also is a takeaway message. If we can intervene early, recovery of energy status, energy availability. This can happen over days and weeks. Increase energy intake, but also it may require us to back off from training. Decrease energy expenditure, drop 15 to 20%. Longer process is really only after we achieve this foundation, improvement or recovery of menstrual status, improving the reproductive hormones, homeostasis, only when we improve the nutrient status of the individual. And then lastly, think about what comes last. What do we see with other individuals? Hair, bones, nails. That often will be delayed, but only after we improve nutrient deficiencies. Okay, so what's the link to low bone mass? Certainly, low bone mass can be caused by accelerated bone loss or failure to accrue optimal bone mineral density. Absolutely. And the risk increases as we miss menstrual cycles. So we want to catch it early. We don't want to move into this months or even years. Stress factors happen in amenorrheic women much more commonly, 2 to 4 times more often in versus eumenorrheic athletes. Severe undernutrition, absolutely. Low energy availability impairs reproductive health, alters estrogen, progesterone axis, and skeletal health, low bone mass. Now, do you need all 3 components? Absolutely not. The combination now has significant negative effects on bone. Now, intuitively, I've mentioned several times that estrogen can be very helpful to bone. Great. Intuitively, it says, gosh, let's normalize those menstrual cycles, and one way to do that is to add estrogen-containing oral contraceptives. But this does not solve the problem. Certainly, estrogen, progesterone, testosterone are all low in the amenorrheic athlete, but just providing an oral contraceptive doesn't treat the problem. You really need to treat the underlying difficulty. It's that energy equation. The addition, in fact, of the oral contraceptive can impact on the IGF-1 suppression. If you reduce it further, then we are not reversing. And the next slide shows an 18-month study with anorectic girls utilizing, for instance, if you use oral contraceptives. If you use transdermal estrogen, we may not see that. We may not see it with vaginal contraceptive ring. But really, all of these studies tell us that more research is necessary in these individuals. So I'm going to take you back to the foundation. The foundation is really improving nutritional capacity. That's where we need to focus on these young women. In terms of eating disorders and bone health, this is much farther along in the concern. These eating disorders have detrimental effect on BMD, absolutely. But even these cannot be grouped. They can have statistical reductions in the hip, whole body, and femoral neck BMD for anorexia, but you don't necessarily see it in bulimia. So even the eating disorders do not act equally. The treatment of poor bone health and eating disorders is impacted by starvation, and it can be a permanent problem. Therefore, we need to impact on the weight restoration and nutrition. Think about getting a dietitian on board, really improving calcium, vitamin D, the protein, the caloric intake. Other risks for these individuals, it may be that they are following a very strict vegetarian diet, lack of physical activity because they have severe fatigue. Excess caffeine, may even have cigarette or alcohol use. So resumption of menses needs to be our goal. And how do we do that? We optimize weight gain and ultimately other conditions, the BMD and energy availability will improve. Specific recommendations, increase energy availability. They need food. They need to fill that car. Optimize weight gain, allowing for resumption of menses. Weight gain alone can have a positive effect on BMD. Weight-bearing exercise, which increases and maintains BMD, and address calcium, vitamin D status, as well as other nutrients. Calcium and vitamin D recommendations, 1,300 milligrams for ages 9 to 18, 1,000 milligrams for 19 to 70. Deficiency, vitamin D deficiency, there are recommendations there for children and adolescents, 2,000 international units daily or 50,000 international units for 6 weeks, followed by maintenance of 1,000. For adults, 6,000 international units or the same 50,000 international units weekly for 8 weeks, followed by a maintenance of 2,000 international units per day. For insufficiency, not a sufficiency state, 1,000 international units daily. Okay, now going through the history, thinking about the history, chronic medical conditions and medications associated with osteoporosis. This one is huge. It's under-recognized and not fully appreciated. The effects of diabetes on mineral metabolism and bone integrity. I am thinking that we all have many individuals with diabetes in our practice. And osteoporosis and diabetes, these are both conditions associated with aging. Under-recognized. Individuals with diabetes are more likely to be vitamin deficient, and diabetes has been shown for the last 15 to 20 years to be associated with an increased fracture risk. And it's not predicted, for instance, if one has BMD, if one has a DXA. For instance, in type 1 diabetes, the risk of fracture is increased by 7-fold and 1.4-fold in type 2 diabetes. Lots of contributing factors. This is a huge area of research. Increased trauma risk, and this may be related to other impacts, musculoskeletal strength, vision, hyperglycemia, and there is an impact with regards to biochemical competence and, for instance, irreversible glycosylation for the bone, so impaired bone quality, and also some of medications, for instance, TCDs. Okay, majority of studies with BMD in type 1 diabetes report significant decrease in BMD at the spine, hip, and total body. What's going on here? There seems to be a correlation with cytokines, the chemical signalers, inflammation, and increased formation of precursor bone cells going to adipocytes rather than osteoblasts and bone formation elements. It doesn't matter. The tools underestimate risk, and these are a group of individuals that we need to have an index of suspicion that they are at risk. In a similar fashion, our patients with rheumatoid arthritis are at risk. Rheumatoid arthritis is an independent risk factor. There's a 2-fold increase in osteoporosis in persons with RA compared to those without. And in fact, the vast majority of these patients are women. They can present with generalized bone loss or periarticular osteoporosis. What are the contributing factors? The disease itself. And rheumatoid arthritis is really a surrogate marker for other inflammatory conditions. Inflammatory joint conditions, psoriasis, lupus. Maybe long-term corticosteroid use, but we've really moved away from that. In rheumatology, corticosteroids are used very short periods of time for flares or for bridging therapy. Or individuals that have bone pain may have inactivity and immobility and muscle mass change. These are multiple contributors, but rheumatoid arthritis has a significant correlation with increased risk. Inflammatory bowel disease is also an inflammatory condition, and there is a widely variant prevalence depending on studies. Osteopenia may be reported 20 to 70% of the time, osteoporosis 17 to 41%. What are the risk factors? Malnutrition, poor absorption of nutrients, the chronic inflammatory state, lean body habitus, low BMI, and the use of corticosteroids. And these are probably patients that we use corticosteroids more often. So that leads me into chronic steroid use. Corticosteroids are used in many areas to treat inflammatory and autoimmune diseases. A reminder, chronic steroid use is really dose and duration dependent. So we want to focus on the lowest effective dose. But if I'm looking at history, thinking about who's at risk when I am looking at premenopausal women, I'm going to have a high index of suspicion. I'm going to want to know how long and how much if it's been utilized. Corticosteroids really impact on all the bone formation and bone dynamic cells. There are a number of key factors and cofactors which are listed here. There's impact on the secretion of parathyroid hormone, and the higher the dose and the prolonged course increases the risk. In rheumatology, we usually talk about it's not a matter of if, it's a matter of when they might fracture, which is why the correlation of really keeping that dose as low as we can for the shortest duration of time. And many of the conditions now have other agents that can be used so that steroids, the really steroid-sparing agent. Hyperthyroidism. Hyperthyroidism, well known, excess thyroid hormone accelerates the rate of bone turnover. Also an alteration in renal calcium excretion with the underlying disorder, muscle weakness and loss of lean body mass, which can be associated with an increased risk of falls. And if one falls and you have reduced bone mineral density, an increased risk of fracture. So in this scenario, evaluation with a DXA or absolute BMD may be helpful in managing care. And that's really the same for the next, for hyperparathyroidism. Calcium levels, and I remember I mentioned the skeleton is really an endocrinology organ. So calcium levels are regulated by parathyroid glands and impacted on vitamin D. Excess PTH leads to an excess of calcium release and reduction in bone mineral density. In these patients, because of the alteration in the calcium stores and the release from bone stores, it certainly has the impact on the bone and increases risk of osteoporosis and fractures. In this scenario, you may want to consider a DXA scan for patients diagnosed with hyperparathyroidism because it can impact on the decision for clinical management and or surgical management. Now, the takeaway, this whirlwind tour, the management of osteoporosis in premenopausal women, prevention is key, but prevention is based on history, getting a complete history. Prevention is focused on universal recommendations for all patients throughout the woman's lifespan. Adequate intake of calcium and vitamin D. Again, childhood, adolescent, young women, lactating women, and women throughout the lifespan. Treatment of vitamin D deficiency, and I included that. Strive for vitamin D sufficiency, which is important to musculoskeletal health. Regular weight bearing and strength training exercise, fall prevention, smoking cessation, avoiding excess alcohol intake. But FDA-approved osteoporosis prescription medications are not indicated for premenopausal women. I usually hesitate to move forward with any medication without a lot of input and a lot of discussion and shared decision making. FDA-approved osteoporosis prescription medications are not indicated for premenopausal women. All right, smoking and osteoporosis risk. Basically, if I look at that picture, I have to say smoking is bad for you and smoking is bad for your bone health. Nicotine triggers a lot of bone damaging changes which are listed here. In premenopausal women, smoking has an anti-estrogenic effect. And we said that estrogen is actually a positive for bone health. Women who smoke are more likely to be thinner, less physically active, having a poor diet or drinking alcohol. Not all of them, but the risk is there, and so history is important. And if you have multiple contributors to a poor bone health, that will contribute to an overall poor outcome. Really the goal is changing the trajectory of bone health, and it means starting early with smoking cessation. The other part of that, I think most women would be very surprised, but actually smokers have early menopause, and again, that impacts on the hormonal axis. Alcohol. My usual discussion here is the U.S. Department of Health and Human Services says women for moderate consumption should really have no more than 1 drink per day. Certainly, high alcohol intake can compromise bone quality, increase risk. We don't really have great outcome data, long-term outcome, it's unclear, as to moderate alcohol consumption, but the standard drinks are listed there. During pregnancy, and I mentioned pregnancy, lactation, calcium and bone metabolism can be altered during pregnancy. That's the main reason we recommend that women plan pregnancy spacing. During pregnancy, intestinal calcium absorption doubles to meet the fetal need for calcium. During lactation, you can see bone mineral contact that is changed. There's a 5 to 10% loss to provide calcium to milk. On occasion, so the third bullet down, there are women who fracture. There are not a lot of them, but the women who fracture are more likely to have secondary causes. Again, that's why I focused on history. History is key. Transient osteoporosis of fracture, Transient osteoporosis of pregnancy is a rare condition presenting in the third trimester, and it usually affects their spine or hip, and we've included that for completeness purpose. But this is really the clinical question. Aren't I getting enough calcium? What if I'm taking a calcium supplement? Is that enough? NHAID's 2009-2010 data showed that 42% of Americans didn't meet their calcium requirements, although intake tends to be better for men than in women. And older adults, the intake is significantly reduced. 1 in 4 older adults is at risk for malnutrition, and that probably has to do with appetite and thirst. But we also see it in younger adults. We see it in adolescents. They are not getting adequate calcium and vitamin D as well through their various diet and even supplements. The focus here in terms of education, nutritional needs should really be met with food. Recommendations for calcium based on age group. As we talked a little bit about the adolescents, 14 to 18 years of age, 9 to 13, 1,300 milligrams of elemental calcium daily. If we look at the bottom, in young, pregnant, lactating women, 14 to 18, is 1,300 milligrams as well. What we're used to seeing is we're used to seeing, for instance, the females, 51 to 70, 1,200 milligrams of elemental calcium. The next, we'll discuss calcium carbonate and calcium citrate, because I think we get this question all the time. The reason many of us suggest calcium carbonate, why? It has 40% elemental calcium. It's commonly available in huge bottles, it's less expensive, and absorption, however, can be affected by gastric acidity, which is why we think about calcium citrate. 21% of elemental calcium, a few more pills, absorbed equally well with or without food, but it may be useful for folks without acid, inflammatory bowel disease, absorption disorders. Taking you back to the calcium carbonate, it is absorbed most efficiently when taken with food. So that's the only takeaway message there. If you take it on an empty stomach, it's not going to be absorbed as well as taken with food. Both are great options. Vitamin D and bone health. This is huge. This is really a huge chemical signaler that there are vitamin D receptors in almost every tissue and every organ system. Certainly, vitamin D stimulates intestinal calcium absorption. The deficiency of vitamin D results in mobilization of calcium from the bone. The body is going to strive to stay in homeostasis. Desirable adult level, greater than 20. Dietary sources are listed: fortified foods, milk, orange juice, some cereals, egg yolks. Survey of childbearing women, NHAID's, showed hypovitaminosis D more commonly in African American women than in Caucasian women. So vitamin D is huge. It's huge in musculoskeletal conditions for bone contraction, every tissue in the body, but also for bone. Also, the recommendation, one shouldn't take calcium without vitamin D, without adequate vitamin D. Same age groups, 9 to 13, 14 to 18, 600 international units. This comes to you from the Institute of Medicine, and those same doses, 14 to 18, pregnant, lactating. However, my recommendation is really to do a dietary assessment. Studies show that we don't get adequate calcium and vitamin D, and therefore we should really assess the individuals in our practice to ensure they're even achieving universal recommendations. Physical activity and bone health in postmenopausal women. This is a very important to recommendation, and so the question becomes, how much benefit does one see? Do we see statistical improvement? And the point is to improve and maximize BMD, but also to hold on and plan for the future. When we repeat bone mineral density, if we are exactly the same, we consider it a win in postmenopausal women. And so in premenopausal women, we are still in dynamic bone change. The benefit is to improve femoral neck and lumbar spine BMD and make sure that we have maintenance of bone mineral density. Benefits of exercise far surpass simply the impact on BMD, improves mobility, flexibility, reduces fall risk, and what we see with physical activity, increased lean muscle, less weight gain, increased insulin sensitivity, less inflammatory cytokines. This really is a win in all fashion. So what do we discuss with our patients? At the beginning, I talked about short bursts of high-impact weight bearing. Short bursts can be very helpful with regards to bone health, bone mass, strength, diminished bone loss, jogging, running, high-impact aerobics, hiking, dancing, jumping rope, stair climbing, tennis. The impacts of studies have really demonstrated that this can be important to bone health. But what about low-impact weight-bearing exercise, muscle strengthening, also critical to maintaining bone strength? Now, what you'd like to see is you'd like to see a little bit of each category. Short bursts of high impact, consistent low impact, and the addition of muscle strengthening as young adults and throughout the lifespan. Okay. In terms of questions, we are going to allow questions to come in by email. The key takeaways for this session. Peak bone mass is influenced by genetic and environmental factors. I've alluded to the importance of gender, race, hormonal factors, nutrition. That's been a key message. Physical activity and lifestyle behaviors. All information that can be obtained with the history. Diagnosis of osteoporosis in premenopausal women cannot be made on the basis of BMD alone. We really need to think about a Z-score of less than or falls below a -2.0 and a secondary cause of osteoporosis, and then use caution, but really focus on prevention. Hormones, particularly estrogen, can have significant impacts on bone growth and maturation, although the data regarding oral contraceptive use and bone health have yielded mixed results. So we need to think about our young population and our young adult population. Medroxyprogesterone is associated with BMD loss, and I shared that with you, although evidence suggests that BMD losses can be substantially or fully reversible. Also reassuring with regards to a good quality contraceptive method. The female athlete triad involves the three components: low energy availability, low intake, and you may or may not see disordered eating, menstrual irregularities, menstrual dysfunction, and then the impact on bone health, bone loss, and osteoporosis. For this group of individuals, it's huge, it's key. It's getting the whole team involved, the individual, the parents, the coach, etc., because early intervention is truly essential to prevent its progression to the more concerning impacts: clinical eating disorders, amenorrhea, and ultimately altered bone quality or reduced peak bone mass and risk of osteoporosis. Recognition of the different chronic conditions, and I focused on some of the nuances to chronic conditions or medications that can impact on bone health, and it's important for improved patient outcomes. Ultimately, the message is prevention is key for premenopausal women. Focus on modifiable risk factors, including alcohol intake, smoking, low body mass index, poor nutrition, lifelong vitamin D deficiency, let's focus on that, low dietary calcium intake, eating disorders, insufficient exercise, and risk or frequent falls. And I think that provides us a wrap for this webinar. Jessica.
Thank you, Dr. Lambing. That was an excellent and engaging presentation, and we truly appreciate you taking the time to come back and provide us with that comprehensive overview of premenopausal osteoporosis. Before we end today's webinar, I'd like to share a few important reminders. Please be sure to join us for the next webinar in this series on October 27th. Registration is now available on arhp.org, where you will also find a recording of today's webinar within the next week. As a reminder, you will receive an email from Caitlin Borswitz in about an hour containing a link to the post-test survey. Your CME or Nursing CE certificate will be generated at the end of the survey. Be sure to print the certificate before closing the internet browser. If you have questions, please email us at education@arhp.org. Thank you again for joining us today. We hope you will take part in other live and on-demand sessions hosted by ARHP.